Hey everybody, it's time to revise and you can do it with me here today. We're going to be looking at schizophrenia from AQA Psych paper 3 and we're going to have some questions on classification and diagnosis, possibly with a little bit of symptoms thrown in, because why not? Alright, let's do it. Right, there you go, there's some exam style questions, you've got timings, here's your chance to pause the video, give it a go, even if you're just planning them, come back when you're ready and I'll talk through how I would tackle them. Okay, let's do it. Right, so which term is used to describe a person having more than one diagnosis at the same time? Well, hopefully you know that that is comorbidity, okay? Co meaning kind of with or together, right? So having two things together diagnosed. This is often confused with the term symptom overlap, which is where you might only have one diagnosis, but maybe there are two different conditions have symptoms in common. For example, like depression and schizophrenia, in both of those conditions you might have a lack of motivation, so avolition, okay? All right. Explain what's meant by validity in the context of schizophrenia. Okay, well, generally, validity is about how genuine or how kind of accurate a concept or a study is, isn't it? Yeah. So you talk about like internal validity and things like that. Yeah. So in this context, validity refers to the extent to which schizophrenia is a unique and genuine condition that is kind of separate from others. And when I say a genuine condition, I don't mean like people are faking it. Okay. What I mean is it something that exists separately to, for example, dissociative identity disorder and depression and bipolar disorder and things like that? Yeah. Is it its own thing? Is it a distinct, unique, genuine category of behaviour? Yeah. You could also argue that validity would be about a person that's being diagnosed with schizophrenia actually genuinely has schizophrenia. Yeah. But validity is about truth. That's the key point. Okay. Right, distinguish between, so we're doing a bit of comparison here, you're telling me the difference between positive and negative symptoms of schizophrenia. Okay, so we have to use an example as well, so we'll come back to that. Generally, positive symptoms are the ones that, they're not good symptoms, that's a common misconception. Positive symptoms are symptoms that add to or distort, kind of like creating an excess, yeah, in a person. Whereas negative symptoms are kind of taking away or reducing or removing a behaviour or a characteristic, right? So positive going up, negative going down, okay? So that's how you're going to explain the difference. Using an example, I think it's a good example in this context to talk about something like speech, because there's a positive and a negative speech symptom, okay? So it's a really nice one to explain the difference. So in terms of a positive symptom, disorganized speech is where an individual will talk very fast or insert kind of random words into their sentences so that it doesn't make sense. You get what's called derailment, where they kind of go off on a tangent a lot. Okay, so that's adding something and kind of increasing. Yeah. Whereas the negative version of that would be speech poverty, or alogia. You might have heard of it being called, which is where there'd be a reduction in the fluency and the speed and the expression in speech. Okay, so it might be quite quiet or very monotone or not, able to engage in a prolonged conversation. All right, but the key point: positive is kind of adding or an excess. Negative is reducing or taking away. Okay, now we've got a bit of application. Many people with schizophrenia also have other conditions. This is what the article is saying. 15% have panic disorder, 29% PTSD. They can both affect a person's concentration and thinking, despite, in the typical population, only 2% and 5%. Okay, so people with schizophrenia are more likely to have panic disorder and PTSD according to the article extract. And the question is, we need to distinguish between, so again, there's, what's the difference? Comorbidity and symptom overlap. Okay, using these as examples. So, knowledge-wise, we went over this a minute ago, but comorbidity is about when a patient or an individual has more than one diagnosis at the same time. Link it to the STEM. For example, in the STEM, many patients with schizophrenia might have panic disorder at the same time, so they would be comorbid, or PTSD. So schizophrenia and PTSD would be comorbid if they had them at the same time. Whereas symptom overlap refers to not having multiple diagnoses, but different conditions sharing symptoms. Yeah. For example, in the STEM, I don't know if you spotted it, but it talks about both affect concentration and thinking. Well, we see that in schizophrenia as well. You might have, be aware of, normally we talk about positive and negative, but there are systems that also kind of talk about cognitive symptoms of schizophrenia. But either way, you'll be aware that schizophrenia can affect concentration and thinking. You've got like disorganized thoughts that is often a feature, isn't it? Yeah. So in terms of symptom overlap, you could talk about how in schizophrenia we see disorganized thinking, and similarly in panic disorder and PTSD, this also affects your thinking and your concentration. So that would be a shared characteristic or shared symptom. All right? Okay, discuss reliability in the context of schizophrenia, referring to research. Okay, I think the refer to research prompt is fine. We could do that talking about maybe the field trials in terms of the reliability figures, or we could do that in the evaluation, or both. Right, up to you. But we need some knowledge of reliability. So let's start off by defining what reliability means. So in the context of schizophrenia, reliability would refer to the consistency of a diagnosis of schizophrenia, maybe across time or across different cultures or between psychiatrists. Okay, so it's about consistency. And you might elaborate to get a bit more knowledge by saying that in the context of schizophrenia, we often talk about what's called a kappa score. Yeah, so the higher the kappa score, kind of a bit like a correlation, kind of, up to 1. The higher the kappa score, the better the consistency of diagnosis. So that's where you could bring in some research, and you might be aware of some figures. I guess it depends which textbook you use, but the figure that I'm aware of for the trials for the current DSM-5 is 0.46. Yeah. So what does that show you? That maybe schizophrenia diagnosis isn't especially reliable. But I know that doesn't sound great, but if you go back before, figures can be even lower, and you might be aware of the study by Whaley, which was done 25 years ago now, and they found that the kappa score, the reliability coefficient, was only about 0.1, so pretty bad. Okay, so in terms of knowledge, we're explaining what reliability is, and I'd probably explain what a kappa score is. You could then use those studies that I've just talked about to try to undermine the reliability and discuss that that's a problem. You could also bring in the issue of culture and the fact that you've got different diagnosis rates in the UK versus the US. You might be aware of the Copeland study, where they gave US and UK psychiatrists a kind of case description of a patient, and the vast majority, it's about 70%, I think, of the US psychiatrists said, yes, this patient has schizophrenia, and only 2% of the ones in the UK did. So that suggests, there's a big disparity, and it's not consistent between different countries, different cultures. Okay, so again, undermining the reliability of schizophrenia diagnosis and classification. I think that's enough for an 8 marker, but if you wanted to, if you're aware of it, you might know the Rosenhan study, on being sane in insane places, where he sent the pseudo patients to pretend to have schizophrenia. You could bring that in as well as evidence against the reliability of schizophrenia diagnosis. Right, so how are we going to tackle this 16 marker? Discuss issues affecting reliability and or validity in diagnosis and classification of schizophrenia. Well, it gives you a choice there, reliability and or validity. So you could split it down the middle and do a bit of knowledge on reliability, same way that basically just do the same essay we've done for the 8 marker to start with. So a bit of knowledge on reliability, a paragraph or two discussing it, maybe with some evidence, and then a paragraph of knowledge on validity and a paragraph or two discussing it. So I'm not going to go over the reliability stuff again because we've just done it. But to then cover the validity part of that essay, you're going to define validity. We did that earlier. It's about the genuineness of the diagnosis or the classification. You could talk about issues that affect it there in the knowledge. So you could do a bit of knowledge on what symptom overlap is, given an example. And you could then discuss the implications of symptom overlap, or discuss evidence to say there is symptom overlap, or what the problem is with symptom overlap. And of course, one of the key issues of symptom overlap is that there's a risk of misdiagnosis. If you've got a patient with let's say, some kind of psychotic symptom, or some kind of, excess mood, or some kind of, I guess I'm trying to say a delusion without calling it a delusion, and maybe avolition or something like that, then maybe that's schizophrenia, or maybe that's bipolar disorder. Yeah, it's quite tricky sometimes, depending on the symptoms, to distinguish those in terms of the classification system. So one of the implications, as I said, of symptom overlap is that risk of misdiagnosis. How are you going to develop that in your discussion? You could take that further and talk about if there's a misdiagnosis, possibly there's going to be mistreatment, or maybe it's going to become a self-fulfilling prophecy, or there's going to be implications for stigmatization, because they've got this particular label, whatever it might be, yeah? Implications. All right, so we've done what is validity, we've done something on symptom overlap. It then probably needs to be said about what comorbidity is, okay? So I would explain what comorbidity is and do a bit of discussion around that. And again, it could be about the evidence for comorbid conditions. It could be about the implications of comorbidity. And again, depending on which book you use, you might be aware of a study where they've looked at the kind of standard of care for schizophrenia patients that have different comorbid conditions. And they found that in many of these patients, the comorbid kind of other physical health conditions tended to get overlooked or a lower standard of care because the schizophrenia diagnosis was kind of dominating their care, okay? So it could be that you talk about the consequences of that. If you didn't know that one or you didn't fancy that one, you could have a discussion about the predictive validity of a diagnosis of schizophrenia and the fact that that is undermined by different comorbidities. Because if you've got 100 schizophrenia patients and they might, half of them all have a random assortment of other conditions, you can't from day one actually predict the course of their condition and kind of, are they going to get better, are they going to get worse, what are they going to struggle with, because of all these different comorbidities that happen with schizophrenia, yeah? So you could talk about a lack of predictive validity that results from all these comorbidities. Okay. How did that go for you? You might well have covered different points to me, that's absolutely fine. Why did it go that way? And what are you going to do next? Alright, that's it for today. That was me discussing the reliability and validity issues in the context of diagnosis and classification of schizophrenia. I hope that was helpful for you. Let me know how you're getting on down in the comments, and I'll see you in another video. Bish bash bosh.